Morning. Um, okay, we're being recorded, so I guess that is my cue to behave myself. So I will try. Um, it's a little hard to stay entertained when I can't see anybody there. So I will ask for some responses. So feel free to unmute there. Just as a reminder, it looks like almost everybody's muted, but if you are not, please go ahead and mute yourself just because we can hear things like your heartbeat um, or at someone using the bathroom. I'm sure everyone would be super excited to hear that. All right. So this is Child Abuse Board Review. So I'm sure there are third years logged in because they need to know this on the day of their graduation. Just kidding. I know that none of them are on here. So these are the content specs that are given of things that we're supposed to cover in child abuse and neglect. This comes straight from what you're supposed to learn during residency. As you can see, it's only about 4%, so not a huge part, but it's not zero. It is something that you should learn during your residency there. They talk about manifestations of abuse, whether it's physical symptoms or behavioral, kind of psychological symptoms. And then they cover categories of abuse. And of course, these are not all the categories of abuse. The big two, physical abuse, sexual abuse, and then the biggest one, neglect. But because it's more interesting or more medical or kind of crosses over to other fields, they also throw in the psychological abuse and then the caregiver fabricated illnesses. And then the last one is kind of your provider roles, which really is mandatory reporting. Family support is more about being a good pediatrician, talking to families, offering them resources, knowing your community resources, knowing where to send them for counseling or such. So, family support is mostly just being a good pediatrician and having resources to send people to. But we will briefly go over kind of mandatory reporting. There's some things that they can't really test on because they're state specific, and each state has different laws or different procedures for going through things. So I've tried to take out any of that and just give you the things that they could test on because it is kind of nationwide there. But I have you guys up to on my other screen, like over here, there. So if you have a question, just, turn on your video, pop your hand up, unmute. You know that I always am very interactive in my lectures. We have more interesting discussions the more you guys have questions. All right, so we're going to start with physical abuse because it's probably the thing that has the most findings, and so something that is testable there. So I always put in fun little things. I would have had chocolate if we were in person because I know everyone gets kind of depressed when we talk about child abuse there. So I tried to put in some funny memes as we were going along. So with physical abuse, it really is kind of Sherlock Holmes and just putting the pieces together. So this is what we do and what you guys would do and how you would answer questions is, does the fill in the blank match the history? So does the location of the injury match the history that the caregiver is giving? Does the developmental age of the child match the history of what the caregiver is saying? This is the severity of the injury match the history? Does the pattern or shape of the injury match the history? Or does the age of the injury match the history? So, examples of this, if a child falls forward and all the injuries are on the back plane of the body, okay, those two don't match. Location of injury and history. Developmental age of a child is really important when you're talking about non-mobile children. So when they're talking about children who cannot cruise or walk, and yet you have bruises, you have fractures, and the child must have done it to themselves. Okay, those don't match. So you'll often get histories like that. Severity of the injury, this is your classic fractures or abusive head trauma. So they have a very significant injury, something that's needing surgery, something that's coming into the ICU, and they're like, oh, they rolled off the couch. Like classic history, the killer couch, the killer changing table, something like that. Patterns or shapes. I'm not putting up all the images of different patterns or shapes, but know that if they're giving you a picture of an injury, a skin finding, oftentimes it will have a pattern to it. And if it has a pattern to it, then 99.9% of the time it's going to be an inflicted injury. It's not going to be something that happens in nature. It's not going to be a rash. It's not going to be eczema. And you guys know your normal rashes and your normal skin findings well enough that your eye should catch that there's a shape or a pattern to it and go, that is not normal. Age of the injury, keep in mind with age of the injury, you cannot date bruises by looking at them. So don't fall into that trap. However, age of injury, classically, they'll give you something like fractures because you get callus formation, you get something that you actually can time there. So I pulled questions out from the New England Journal, NGEM. What does that stand for? Anybody know? Silence.
New England Journal of Medicine.
Okay, thanks, Liz. I thought that was it. So I went and got questions off of there. There were only a couple, but just as an example. So this one is a physical abuse, a fracture one. So 12-month-old girl is brought by her mother, 2-day history of fever, congestion, and wheezing. So that's your red herring there. So she comes in and she's sick. So what we're going to find is going to be an incidental finding. So she was born at 35 weeks gestation, has eczema, but otherwise fine. She just uses triamcinolone cream. She's formula fed, but she's also eating solids, so no weird diet there. Family history is unremarkable. Mom gives the history that we always hear. She rolled off the couch about a week ago while she was sleeping, which would be developmentally appropriate for a 1-year-old. They can certainly roll and crawl. She probably is even walking, but doesn't think the child hurt anything. Now, on exam, they give you that she's tender over her anterior chest. So this is just meant to help you. Highly unlikely in real practice that you'd ever get chest tenderness with rib fractures. And so chest radiograph is obtained and has posterior rib fractures. So which one of the following diagnoses is likely? All right. So inflicted injury is physical abuse. Like obviously we're in the child abuse section. So that's going to be the answer. The osteopenia of prematurity, they're giving to you because she was born at 35 weeks gestation. So you're meant to know that 35 weekers are not really preemies. Like they're fine. Their bones are healthy. Here, they're giving you osteogenesis imperfecta because that's what everybody says. But when you look at her radiographs, her bones look just fine. You got arrows at the rib fractures there. These are actually pretty significantly healed. Like they have callus formation there. And here you can even see some remodeling on this side. So she really shouldn't be tender over her anterior chest because these fractures are not painful at this point. So I'm not exactly sure. I think they're just meant to help you focus on the chest there. But also when you talk about a 12-month-old with normal development, she's walking, she's climbing. If she had osteogenesis imperfecta, she would have had a history of more fractures. And then they're also giving you very specific fractures, posterior rib fractures, which are highly specific for physical abuse. So, you know that it's not osteogenesis imperfecta. Steroid-induced osteoporosis, again, you can look at the x-ray and everything looks just fine. and I mean, and vitamin D deficiency rickets, you know, she's formula fed and she's eating solids. And again, her bones look fine. So when you're looking at radiographs and they're normal, you can pretty much rule out anything like osteogenesis, osteoporosis, rickets. They have findings on x-ray there. And this kid looks perfectly fine with her bones, like normal mineralization and such. Family history is also really important. If they say it's unremarkable, then you probably don't have anything genetic as well. And then the other thing, they might throw in like an accident because they said this roll off the couch there. And so you just have to know that posterior rib fractures are very specific for compression on the chest. They're not going to be something like a simple accident. So when you're talking about fractures, you're matching the fracture type with kind of the injury and the mechanism that they're talking about. So a fall off a couch would be a fall, you know, a short fall onto a flat surface. You know, what kind of injuries do you get there? Certainly not rib fractures. But this is kind of how you think about it. So rib fractures, you know, they're anywhere from 5 to 51% of all fractures in abused children. Keep in mind, if you have rib fractures, less than 1% are accidental trauma. So if you're playing the numbers, if you're getting rib fractures, it's most likely to be inflicted. You know, just quoting a study, kids with severe blunt force trauma to the chest, so we're talking car accidents, only one had a rib fracture. And doing CPR with your hands encircling the chest, you know, doing anterior posterior compression does not lead to rib fractures. So it's not CPR related. Usually, you know, they come in and the family's like, I have no idea what happened, which is pretty classic. There can be non-specific symptoms, so respiratory symptoms, fever, irritability. And so if you go back to this case, like fever, congestion, wheezing, that, you know, could be something there. But again, these rib fractures are healed, so more unlikely. But I think that's what they're trying to get at. GI upset, poor feeding. Rarely do you hear crepitus, so popping in the chest. The other interesting thing is infants is it's a paradoxical reaction. So they cry more when they're picked up and they are happier when they're put down, because when you pick a child up, you have compression or pressure on the chest. And so it irritates those rib fractures. But this seems to be something that they like testing on. So when you're seeing rib fractures with a normal chest x-ray, otherwise, you need to be thinking about inflicted injury. This is also a very uncommon injury in birth trauma. So even when you get the little kids, young infants, you know, you need to be thinking. The other fractures that they'll hit that have a high likelihood of being abusive are your classic metaphyseal lesions. They're called corner fractures or bucket handle fractures, most often in your infants less than 6 months of age. Scapula fractures, including the acromion. These often will show up as well with abusive head trauma, so will CMLs. Sternal fractures. These are high energy blunt force trauma. Think about adults stomping on kids' chests. And in these cases, they may ask you, you know, you may identify that's an inflicted injury, and then they go one step further and they're going to ask you to like check troponins and check for cardiac injury. And also fractures of the spine. So axial loading is when a caregiver grabs a child and slams them down. And so you get axial loading from the head kind of to the coccyx. And so that will give you spinal compression fractures in young kids. They can also be from blunt force trauma to the spine. And we see this as well in particularly violent abusive head trauma cases. So when you're looking at questions and you're looking at rib fractures, CMLs, scapula, sternum, spine, abusive injuries should go to the top of your diagnostic list. And the other things that they may throw are generally going to be red herrings, although they do like, some of the abusive mimics at times. So, any questions kind of about fractures? Everyone's still getting their coffee. Okay. All right. Moving on. So this always comes up. It's always an option. Just remember OI, it's very heterogeneous, but it's a type 1 collagen mutation. There's over 200 gene mutations, 7 types. The phenotype, even in a family, is very variable. And so you have different mutations, mosaicism, different expression in tissues. However, there are some variants that are lethal at birth and then some that are lighter in severity. However, when you look at these kids' x-rays, they are not going to look normal. And generally, they'll give you a skull film that shows you kind of those Wormian bones there. It's only diagnosed by genetic sequencing. In general, I don't even think they're doing the pro-collagen from fibroblasts anymore. Generally, it's more genetic sequencing. But in order for them to test you on this, generally there will be some family history, or there'll be a history of fractures either at birth from the birth process, or the child will essentially start having fractures the minute they become mobile in any way, shape, or form there. So generally this answer is going to be incorrect on the test, but it shows up and people get tripped up because they're like, oh, is this OI? Trust yourself. You know what normal radiographs look like now. And so if the radiographs are looking normal, then you can pretty well rule out OI. The other thing, they'll have to give you like the blue sclera, some other manifestation there. The other ones, so these are things that were given as options there preterm birth. So osteopenia of prematurity is a thing, but you have to be really preterm. So we're talking your 24 weekers, your 26 weekers. They also have to have prolonged TPN. So it essentially is a deficiency from prolonged TPN. So if you have, a healthy 28, 32 weeker, no TPN, then you're not getting it. It's also limited in age, so 6 to 12 weeks postnatal age. So this is something that is happening while the child is still in the NICU, either as they're getting off of TPN or as they still have TPN. So in our example, a 12-month-old who was a 35 weeker, like absolutely not, couldn't happen. Rickets, vitamin D deficiency, they have to give you something like breastfed infants without any supplementation of vitamins. Maybe the mom has a really weird diet that they're on. Maybe mom is agoraphobic and she stays in, like there has to be something very significant in the diet for the children to get rickets. And then you're going to see abnormal radiographs. So they're going to give you the rachitic rosary or the widening at all of the bones. So it won't be just one bone. It will be something pretty profound. Osteomyelitis, it can resemble CMLs, but again, they're going to have symptoms of infection. Copper deficiency, we had a kid who had this. Sometimes they throw it out, but generally they have to have the genetic or metabolic disease. And then always keep in mind that kids who are immobilized or paralyzed for long periods of time can have osteopenia, kind of osteoporosis, and get fractures more easily. But those are your ICU admitted kids for a long time. So just throwing these out there so that you know what they are, but when they do questions, they make it pretty obvious. All right. So this was an 18-month-old girl not moving her left arm for the past day. Mom says that she can't remember any accidents or trauma, but, she falls a lot. And she's been walking, kind of within normal. So she started walking at 15 months of age. So there's swelling to the upper arm and pain with passive motion, and x-rays reveals a spiral fracture of the left humerus. So when you're assessing this, spiral fractures do not always mean abuse. However, there's no trauma history whatsoever. She's just falling down. So they want you to know that this is abuse, because if you're just falling down kind of at an outstretched arm like most kids do, you're not going to get a spiral fracture because that requires twisting on the arm. So they're asking you to know that it's abuse and then go one step further. So what do you do next to evaluate this child's condition? So the MRI, they're asking you, if you think there's osteomyelitis, an infection, some underlying issue there, they would have given you something on the x-ray. Radionuclide bone scans, just something else that you can do. Serum vitamin D level, if you think that it's vitamin D deficiency, but again, they haven't given you that the x-ray looks funky in any way or that there's a weird diet. And then, of course, osteogenesis imperfecta. The kid started walking 3 months ago, and this is her first fracture, so highly unlikely. So knowing that it's abuse and then ordering the skeletal survey. So this is the skeletal survey. It is not a babygram. If you see babygram, that's the wrong answer. So they will call it a skeletal survey. You need to do this for any child with suspected abuse, like physical abuse, under the age of 2. So you're always going to be doing it. It's always part of the workup. Just keep in mind, you don't do it in children over 5 because it's too much radiation. Then we do targeted films there. So I've seen some older kids get it, but it has multiple views there. So this one, 7-week-old, comes to the ED via ambulance after his mother had difficulty awakening him for a feed. The child is going to a babysitter since she returned to work, and babysitter is saying for 2 days the child has been vomiting, seemed fussy. Now, when he comes in, his vital signs are okay, but he's lethargic, hypotonic, and pale. So he's, in distress there. It needs emergency intervention. He has bruising to his left ear and bruising to the posterior parietal portion of his skull there. So they've given you kind of neurologic symptoms, difficulty awakening, vomiting, fussiness. So there's some kind of neurologic injury here. They've given you his head CT, and they have nice arrows. So you can see the cephalohematoma that they were talking about, an obvious skull fracture there with part of it depressed, and then some kind of hemorrhage outside of the brain. Don't really know if it's subdural, subarachnoid, not exactly clear there. So obviously there's no history to account for this. This is a very significant injury, and it implies blunt force trauma to the head because there's a skull fracture and a cephalohematoma. So this is a form of abusive head trauma. But then, so you stabilize the airway and you get neurosurgery involved because of the hemorrhage and things may need to be drained. But then it asks about what your next step would be. So yes, you need a skeletal survey, but when they say whole baby radiograph, a babygram, they're tripping you up because we never do babygrams whatsoever. It's not something that we do. It's not something that's used. And when they are saying that, they're trying to trip you up there. Ophthalmology consultation. So in this case, this looks more like blunt force trauma and less like a shaking kind of rotational injury. You probably will get it at some point, but it's not the next step in your management. Lumbar puncture, this doesn't look like meningitis. Like if you do a lumbar puncture, you're probably just going to get blood. And also, you don't know, they've got open soft spots and such at 7 weeks of age. And so it's probably not dangerous, but also not your best thing. And cryoprecipitate, I'm guessing they're thinking about clotting problems, but they don't give you any coags or such. And so that's not what you're just going to jump off to. The most appropriate step and what the answer was notification of CPS. So at this point, given just what you have, you know that this is more than likely abuse. You have a high suspicion for abuse. And so you need to activate those services. So there are other things that you may do, like you do need a skeletal survey. You may get an ophthalmology consultation. Maybe at some point you're going to do a lumbar puncture, although you can get samples when neurosurgery goes. And maybe they have issues and you're going to need to address their coagulation problems. But they're all slightly wrong. Kind of for the reasons that I just kind of said. So when you're talking about abusive head trauma,
Dr. Lamb.
Yeah.
Sorry to interrupt. I have a quick question. They aren't going to ask us to try and differentiate between abuse versus like osteoporosis in a non-developmentally normal child, are they?
So if they're going to talk about like osteoporosis or that, they're going to give you things in the STEM that makes it very clear that this is not a normal child. So they're going to be like trach and G-tube dependent and non-mobile, or they have a several month hospitalization in the ICU there. And so it's going to make it abundantly clear that if the child's bones are fragile there. And so then just based on that STEM, any kind of fracture, you're going to bump way down on the abuse ladder because it's more likely that this child has fragile bones. So it's going to be abundantly clear in the STEM there, or they're going to make it abundantly clear that this is mostly a normal child. Does that answer your question?
Yes, it does. Thank you.
Yeah. So they're not like, they're going to, just like all board questions, like when you're going back here, like they're almost right answer. So they're not going to give you things that are like wildly wrong. But they're not going to try to trip you up. Like this 7-week-old, they've given you a kid past birth trauma. So like you can see subdurals and some things up to, about 6 weeks or such. And then they've also made it wildly clear because you have a fracture plus a cephalohematoma plus an intracranial bleed plus a history of acute neurologic symptoms. So clearly this is not related to birth. So they don't, because child abuse is so it's not like mainstream. It's not like infectious disease or cardiology or, pulmonology. And so they tend to make our cases kind of clear there.
Hey, Dr. Lamb. Hey, I have a question too. Sorry. You had mentioned on the previous question that, it was clear that it wasn't a shaken baby situation. So if for some reason the question was a shaken baby situation, at what point would you have to do one of these other answers before notification of CPS? Because I feel like that would always be the right answer.
So essentially it's asking what is the appropriate, so the best next step there. And so in this situation where it's pretty clear that it's abusive, so even if it was more of a shaking injury or such, I think notification of Child Protective Services would still be your next answer, because you don't need to do x-rays or ophthalmology or such to help make the diagnoses. You kind of already have it there. And they gave you airway stabilization and neurosurgery as the things that you need to do to stabilize the child. So it kind of goes in that stepwise, like things you need to do to stabilize the child, then notification, and that's seen as assuring the child or any other sibling's safety there. Then you can get into more diagnostic procedures to see if there's any other injuries or such. So it generally would be notification of Child Protective Services. If they gave you a skeletal survey, that's the only one where I would kind of be torn between the two answers.
Okay. All right. Thank you.
No problem. All right, so talking about abusive head trauma, so you shouldn't see anything like shaken baby syndrome. Generally, the boards are a couple years behind, but this came out in 2009, so we're talking a decade ago. And so this just says, although shaking an infant does cause injury, there's blunt impact or a combination of injury as well. And you also get spinal cord injuries and secondary hypoxic ischemic injuries. So you should see this broad term. So generally, classically, or abusive head trauma, you're going to have subdural hemorrhage and cerebral edema. You may or may not have retinal hemorrhages. They're only in about 80% of cases, which is why you don't use ophthalmology or retinal hemorrhages as a screening exam, because even if it's negative, that's still 20% of abusive head trauma cases. The history usually is absent or minimal. So that's where the severity of the injury doesn't match the findings that you have. So these kids are they're going to give you kids that are coming in for the ICU. And the history is either, oh, I don't know, or a roll off a couch, a fall out of a caregiver's arm, something very low velocity. Remember that you can have fatal injuries even without any external trauma. And usually they'll give you something else. So in that previous case, they gave you those ear bruises. And so that is very highly specific for inflicted injury. So they'll give you rib fractures, metaphyseal fractures, or bruises to help make it abundantly clear. All right, just a little break. All right, question. So abdominal trauma, these don't show up as often, but I'll just touch on them. It's a slow symptom evolution. Think peritonitis, often an insidious onset. It can take hours to days. They can come in hypotension and cardiovascular collapse before detection, or if they hemorrhage internally. So it is not a frequent cause of pediatric trauma, but once you have abdominal trauma, as much as 20% is inflicted. So if you get a question and it's abdominal trauma and there's not, a high velocity car accident or such, you need to just have it in the back of your mind. So when you're talking about it, if it's a solid organ, it lacerates, it bruises, so liver, spleen, pancreas, kidneys. If it's hollow organs, then they get pinned up against the spine. And so you can get hematomas, you can get rupture, you can get leakage. And then keep in mind that the vessels are also subject to injury. So I just throw this out there as if you have an abdominal trauma, keep in the back of your mind that they may be getting at the fact that although it's infrequent, as much as 20% are abusive. And so they may ask you to identify that. All right, bruising. This also has been out there for several years. And so this, they can test you on. So if you see bruising to the torso, to the ears, to the neck, anything under 4 years of age, more than 4 bruises on a child, or bruising in an infant when they're non-mobile, then you need to be thinking about inflicted injury. So in that child, this case back here, they gave you the bruising to the left ear. So they kind of threw that in to help you make the determination that this was inflicted injury in a non-mobile child. So they can test you on this. These are kind of the high value bruises that are very specific. All right, any questions about physical abuse? That's the one that has the most physical findings. Nope. All right, sexual abuse. This is super quick. All right. Sexual abuse is any sexual contact or exposure to sexual acts. It's anyone having sex before the age of consent, but they can't give you an age because it's determined by state law there, or someone who's developmentally incapable of giving informed consent. So even if they're 18, 19, 20, but they have the developmental level of a 6-year-old, then they cannot give informed consent there. But generally, this second point is so variable by how it's interpreted state to state that they won't test you on it. They will get you on the sexually transmitted infections. So any sexually transmitted infection in a child under the age of consent demands a report and investigation. And don't forget about child pornography. With the internet crimes and the phones, sometimes they like to harp on this, people soliciting photos from children or sending children photos. So, question. 5-year-old comes in by his mom who's concerned because he's trying to pull down his 4-year-old sister's underwear despite her protests. The episodes have occurred daily for several weeks. When mom tries to separate the boy from his sister, he becomes transiently aggressive, then calms. No medical history, growing well, is showing signs of school readiness. So, this is kind of his kindergarten well child check. Mom says the two kids have bathed together. And she remembers several times when they were younger where they'd briefly touch or stare at each other's genitals, but they were always playful and easy to distract. Mom also remembers the boy attempting to lift her shirt several times when he was about 3 to 4, sometimes in public, but this stopped after she corrected him. And then several times recently, she noticed him touching his genitals before falling asleep. And in some of those instances, he has facial flushing and heavy breathing, and she hasn't intervened. All right. So this question, so starting at the end, the touching his genitals, that's normal masturbatory behavior. Mom trying to lift up her shirt, 3 to 4 years, sometimes in public, but she corrects him at a stop, is normal. Bathing together, and realizing that they have different genitals and kind of looking at them because they're different than what they have and are distractible, that is also normal. So then you get back to this pulling down his 4-year-old sisters despite the child telling him to stop. And then it's been daily for several weeks. So it's going on. And when mom tries to separate him, he's transiently aggressive. So that puts it in the category of kind of inappropriate. So if that was not there, then you just reassure mom that this was fine. Anytime they throw in words like sexual predator, so essentially this is saying that you think the child has been sexually abused. And then you're like, whoa, that's way overdoing it here. Psychiatric evaluations in a 5-year-old, like that's just crazy talk. And then suggesting that mom attempt to distract the boy when he's masturbating, that can be, but it throws in does not escalate into a problematic behavior. So the masturbation is not a problematic behavior. He just needs to know that he only does that when he's in private, that it's not something that we do in public or do to other people. So the only one that kind of gets there is interview mom and child separately to ascertain recent stressors. It's an okay answer. It's better than the rest of them but this is something that, they kind of want you to know. And so they throw in a lot of things that are normal. And then they give you one kind of part where you're like, okay, him trying to pull down his sister's underwear, may be normal, kind of an extension of exploration, but they're like, the child's protesting, it's gone on daily for weeks, and he's transiently aggressive. So they throw those things in to try to let you know that this is an inappropriate sexual behavior, and it needs to have some intervention. So this is almost kind of a general pediatrics thing. So you're talking to mother and child to try to see what's going on. When they talk about talking to mother and children, they always are going to tell you to do it separately because that standard of care in child abuse evaluations. If you're concerned about abuse for any reason, you always have to separate caregiver and child and talk to them separately. So I think that's why this second question becomes kind of the correct question. All right. And then you're going to get STIs. So a 6-year-old girl comes into foster care 2 weeks ago because of suspected abuse by her stepfather. So now she's having a 1-week history of dysuria and vaginal discharge. She doesn't have any prior medical issues, has not been on antibiotics. And then she doesn't report any other symptoms of vulvovaginitis. So like itching, bubble baths are a chemical irritant, and so it can often lead to vulvovaginitis. And then wiping from back to front can also lead to vulvovaginitis or urinary tract infections. So it's not really clear from the first part, but then when you go to physical exam, you know, her hymen's normal, which doesn't mean anything because 95% of kids who have been sexually abused have normal hymens. But they give you the erythematous vaginal vault and a copious thick green discharge. No recent signs of trauma there. And so then it asks you to just pick the STI there. So it's not from her butt, so you don't have pinworms. Doesn't look like a yeast infection there because you have this copious thick green discharge. You know, it's not white satellite lesions or kind of a white discharge there. Vulvovaginitis due to poor hygiene, again, the copious thick green discharge, and they've already told you up here that there's no itching, bubble baths, or wiping back to front. So they're trying to steer you away from vulvovaginitis related to hygiene. So that leaves you Neisseria and Trick here. I actually got this one wrong. I generally think of Trick as having a green discharge, but they wanted you to pick Neisseria. So if you can remember it, it's the gonorrhea pool and the chlamydia river. So I think because they're going like copious and thick is why they're going for the gonorrhea. So gonorrhea has a very viscous, thick discharge. Chlamydia, it's a profuse discharge, also relatively thick. And so they want you to go to this. They've also given you that there's suspected sexual abuse and it was 2 weeks ago. And that's the perfect, you know, time for in the right time frame as far as getting infected and then showing symptoms. Liz, did you have a question? I just saw you unmuted. I'm guessing no. All right. So moving on to teenagers, STI testing. So this is a 16-year-old, 2 months of vaginal discharge, and again, 2 weeks after a sexual assault there. So giving you the same kind of, oh my gosh, I can't even remember, the same time frame. Otherwise, she's healthy. You do her exam, and she has erythema of the vaginal vestibule and scant yellowish discharge at the cervical os. There, no cervical motion tenderness, so you're not worried about PID. And of course, she's positive for chlamydia. So like the yellowish discharge, that's the chlamydia river, negative for gonorrhea. She doesn't have the gonorrhea pool. So you're going to do HIV and Trick, but it asks you which is the other one that you test for, because she clearly has had sexual contact that has resulted in one STI. What is the other one you need to test for? And it's syphilis. So she doesn't have any vesicles or any history there, no visible warts. And even if you tested for warts, you know, what are you going to do with the testing? It's obviously not just kind of BV there, and not a yeast infection is not what they describe on exam. So remember, when you're talking about sexually transmitted conditions, the ones that you can test at 2 weeks for are the chlamydia, gonorrhea, and Trick. 2 months out is your HIV and syphilis with the new antigen testing that we can do with HIV. And then somewhere in the middle is kind of pregnancy. So herpes and warts are STIs, but they can also have innocuous transmission. They're not diagnostic of sexual contact, but they do warrant evaluation in kids who are not sexually active there. So sometimes they try to trip you up with herpes or warts. All right, so this one I actually pulled from the altered mental status part. So this is a 19-year-old college student who comes in to the ED by ambulance when campus security found her wandering around confused. So she was at a campus party and then she remembers nothing. She has abrasions to the extensor surface of her arms, but also to her medial thighs, and she has abrasions and bruising of her labia minora. No head trauma. So, they give her mental status, her urine drug and serum drug testing are negative, her head imaging was negative. So they're asking about this episodic memory loss, and it's a dissociative amnesia. But I wanted to highlight this for the sexual assault exam. So this kid also needs evidence recovery because she has evidence of acute genital injury, abrasions and bruising of her labia minora with no memory, after this campus party. So this is certainly less than 72 hours from when a sexual assault would have occurred to when she's in the ER. So this is a time-sensitive exam. It's indicated with any evidence of acute injury on anogenital exam, laceration, bruises, abrasions. You calculate the time from the time of assault. Generally, you can keep 72 hours in your mind, although it's actually 24 for prepubertal children. It's done by specialized nurses or physicians. There, it identifies acute injuries and photo documents that injuries, and then it provides post-exposure prophylaxis for pregnancy and STIs in adolescents. There, so sexual abuse may crop up in other questions that you're going to see. All right, any questions about sexual abuse? All right, moving on to neglect or acts of omission. So this is listed as one of the categories, but there's not a whole lot to talk about with it. So neglect is failure to provide for a child's needs. So the types you're going to see are physical neglect, not providing for their physical needs, emotional neglect, which we're going to talk about as psychological abuse, educational neglect, supervisory neglect, medical neglect, which they may hit on, and the nutritional neglect or failure to thrive. So neglect is very prevalent, but usually questions focus more on physical or sexual abuse. So just remember with your failure to thrive, nutritional neglect, inadequate weight gain, deviation from growth standards. So it's always based on the growth chart. And so if a child, we're talking about young children below the 5th percentile on more than one occasion, they're less than 80% of their ideal weight, but generally they'll give you a child whose weight crosses 2 major percentiles. And sometimes they'll ask you when to hospitalize. So when there's signs of severe malnutrition on exam, they're below the birth weight at 6 weeks of age, no weight gain in 2 weeks, or not enough weight gain, so inadequate weight gain at 4 weeks, if the head circumference is effective, if it falls off, because you lose weight first, then length, then head circumference. You lose head circumference, then you're losing brain cells, and that's irreversible. Or if you see signs of neglect, if the caregiver just is not able to care for the child, or if you've tried outpatient therapy, interventions, WIC, teaching, and it's not working. All right. Questions? Nope. I'm just rolling along. All right. Behavioral and psychological manifestations. I know everyone's feeling like this at the end of the year there. All right. So this is where we kind of cross into psych. An anxious 13-year-old comes in with his mother because he was straight A's and now he's failing. And he's also started using marijuana. During the visit, mom, is moving, and you see what appear to be bruises on her neck and chest. So this is intimate partner violence or domestic violence. So the next appropriate step. So the child is showing signs of stress, failing classes, started using drugs. You kind of have an idea of what it is because mom is bruised there. So what do you do next? So this is one where, you know, if you call the father to determine what's happening, you just let the abuser know that someone may know, and you place the family into danger. So you're not going to do that. Introducing general concepts and wait in front of mother and child and see if they respond. So this is going to be inappropriate because you're talking to the mom and the patient together. And when you're dealing with any abuse or neglect, you're not supposed to talk to them together. Contact CPS. Okay, you can't contact CPS because it's mom who's being abused, not the child. There are no injuries to the child. The child is clearly being affected and showing signs of stress, but you don't have any evidence that the child is being abused. So discuss your concerns about mom with the child. Okay, this is a 13-year-old, not an adult, so that's inappropriate. So the one they leave you is kind of talking about your concerns with mom in private. Now, obviously, you'd also talk to the child in private, but they don't kind of give you that option. So when you're talking about domestic violence, remember, you need to worry about physical abuse. You need to look at other siblings for physical abuse. You speak to mom and child separately about what you're observing. You provide resources to mom, but since she is an adult, you cannot do anything against her will. So if you make an offer to call the police, have them respond. If she's like, no, I don't want to report it. If you give her domestic violence resources and let her call or offer to call with her and she's like, no, I don't want, you cannot do anything. It's adult medicine. But when your role as a provider for family support, you can discuss lots of resources, counseling for the child, counseling for the mom, drug treatment for the child. So in these scenarios, oftentimes they ask you to take kind of a supportive role. All right, this is kind of similar. So 15-year-old boy is having difficulty in school, has been down, and has lost 3.2 kilos in the past 3 months, but otherwise he's normal. So no evidence of any organic medical disease. So this one came into the child abuse, but it's really psych, and that's because we see so many of these kids. So highest rate of suicide, and then they give you right here suicidal ideation, and you're like, oh, that's easy. So the other ones are risks for suicide, but the highest risk is obviously if this child already has ideas of suicide. So this would be kind of your normal pediatrics, doing the screening, talking to the child, and seeing where they are. But they give you this in our section because it can be a manifestation of abuse, or it can be a manifestation of stress on the family. This is another suicide one. I'm just gonna kind of skip this one. This one they just go to, she has daily thoughts and has a plan. And so this patient you need to hospitalize. Like you can't safety contract, you can't do anything else. Like she says she's got a plan and she says she's gonna kill herself. So you have to put her in the hospital. All right, manifestations of maltreatment, it can be anything. Change in school performance for better or for worse, behavioral issues at school or at home. It can be diagnosed as ADD, ODD, depression, anxiety, regressions in development, or it can be parentification, like becoming more like a parent. So these are not specific for abuse, they're specific for family stress. But they'll oftentimes give you one of these symptoms. So I was like, okay, I can cover it, and they'll give it to you, but it's not pathognomonic or linked to abuse. It's a sign of family stress. All righty. Psychological abuse, also known as emotional or verbal abuse. It can be something you do, it can be something you fail to do, and here are the subtypes. I'm going to send out the slides so you guys are fine. So it's a repeated pattern or extreme incidence of caregiver behavior that thwart a child's basic psychological needs, their need for safety, socialization, emotional, social support, cognitive stimulation, and respect. It conveys that the child is worthless, defective, damaged, unloved, unwanted, endangered, only useful for meeting a caregiver's needs, or expendable. So the spurning subtype is where they reject and degrade a child. They spurn them, they turn them away. Terrorizing is where they threaten or are likely to physically hurt, kill, or abandon the child's loved ones, or objects there. So this can be threatening children's siblings, a loved parent. Objects can also include pets. So you're going to see this oftentimes with kind of domestic violence there. It also can go along with kind of child torture. Exploiting, corrupting. This is where they encourage or involve children in illegal activities, antisocial activities, deviant or maladaptive behaviors. Emotional unresponsiveness is ignoring. So they don't bond with the child and they just ignore the child. And then isolating is where they keep the child from interacting with peers, adults inside or outside the home, and just keep them isolated there. I haven't seen any questions about these, but it's listed as one of the content specs. So I thought I'd throw it in there and give you guys the definitions just kind of for your information. All right. Medical child abuse. Experiencing unnecessary or harmful or potentially harmful medical care at the instigation of a caregiver. This is what they call caregiver fabricated illness. So I'll just say that it presents many different ways. It ranges in severity. It's not an illness, but it can, look like it. And they may have different motivators. And oftentimes the perpetrators have their own mental health issues on this. Remember, you're a mandated reporter, and it's based on suspicion, not absolute proof, and you're protected from prosecution. So congratulations on finishing your year, or almost there. I will let Whitney send out these slides just in case they're helpful, kind of with the high value targets. And so if you have any questions, I will take them now. I know I'm 1 minute over.
Thank you very much.
No problem.